Oh, I didn't see you guys come in. My goodness.
Hey, is this thing on?
Hello?
What's going on, everybody? Welcome to another lesson in the most elite medical school around. Today's topic will be contraception. So this is basically our sex ed portion. And as we know, we're a fundamentalist religious institution here at Elite Medical School. And, our traditions go back millennia. But we've been told, apparently, the pull-out method and anal are not really enough to cover sexual education in our state. So, at gunpoint, we will be talking about some contraceptive options available for us. Now, who's joining in for this blasphemous lesson today?
Well, I'll be joining you guys today, Dr. Dre. I consider myself somewhat of a sexpert, and have a wide range of experience in terms of contraception. So I'm happy to join you guys today.
I'm Dr. PhD. I haven't had sex yet, but I really just want to get all the information first before diving into it. It can be a loaded encounter.
That's true. Very loaded. High load topic today. All right. So why is contraception important? I'm not sure how much action our listeners get, but I would say for the most part in the general population, aside from our listeners, almost 100% of people will practice some sort of contraception at some point in their lives. And no matter what specialty you work in, many of your patients will have concerns about conception or contraception and will be asking for your advice. And many people that you'll encounter in your practice may even underestimate the risk of unintended pregnancy. So, even though this topic, maybe I'm coming in with my bias. When I was in medical school, I felt like, why are we learning about this? Isn't contraception common knowledge? It really isn't. A lot of people are just not that well acquainted with what is available out there, what the risks are. We need to help them out.
Wow. So what are the most common forms of contraception? We have abstinence or celibacy, and that's what people like Dr. PhD choose to pursue. We have barrier methods such as condoms and female condoms. Those can be fairly high yield and are protective against STI, especially. But for the purposes of this chat, I think it'll be useful to focus on hormonal contraception as well as IUD. Because these are serious medications with potential serious side effects, and so being an informed prescriber is important. So let's use a case-based approach. You have a young woman who comes in. She's Dr. PhD's ex-girlfriend, so she's sort of sexually starved and is really looking to get herself on the market. Plans on having a lot of unprotected sex. Also has a few relevant medical history features, including fairly severe acne and elevated body weight. So with that in mind, she comes asking. She says, "Doc, I can't get pregnant. I'm pursuing medical school. I certainly can't get pregnant. What are my options?" So starting with a history and physical, what elements should we focus on to determine whether or not this young woman is a candidate for hormonal contraception? Well, we'll likely start with a blood pressure and ask about any cardiovascular risk factors. There are a number of absolute there are a number of contraindications to hormonal contraception, including migraine with aura or complex migraine. It's technically an absolute contraindication to estrogen. However, exceptions are made. We'll collect that blood pressure because both estrogen and progesterone can increase blood pressure. And then finally, we'll ask about any personal or family history of VTE or venous thromboembolism, because the estrogen increases that risk by about threefold, depending on the formulation. So not insignificant at all, especially in women that have an underlying risk. So what other sort of contraindications might we discuss for the use of hormonal contraception?
In terms of other like straight up absolute contraindications to hormonal, if they're currently pregnant or they may be pregnant, you would probably want to rule that out before giving them birth control. So doing a beta HCG would be a great call as a lab test to do before you start oral contraceptives, hormonal in somebody who is currently sexually active. Other things being if they have just like an undiagnosed vaginal bleeding disorder or it's abnormal in some way or form, you'd probably want to work that up first before just agreeing to give them some oral contraceptives. As you mentioned, venous thromboembolism is a big thing and can be increased in hormonal, so you want to work that up. Any family history or personal history of VTE or coagulant disorders. Any kind of history of a cerebrovascular accident or stroke is another contraindication. Very unlikely would be if they had a primary breast or uterine cancer. And I think that's about it. You mentioned the aura and migraine.
There's one other let's say common one, and that is smoking. So women that are greater than 35 years old and are active smokers, that is considered a quote unquote absolute contraindication.
I thought the patient was young.
Yeah. Well, you're right. We're not. Well, no, I thought your ex-girlfriend was like 45 or something like that.
All right, moving on.
Yeah. Likes them post-menopausal.
Yeah.
Now, before the podcast, Dr. PhD was actually asking some questions about his GF, non-GF, XGF, whatever. He's worried that it will make her gain weight because he really wants to keep her slim, Some people may say that's misogynistic. As a professional, I tend to not judge. But what do we say to the patient that says the pill's going to make me gain weight?
So this issue's been considered specifically, and there's no good evidence that these pills, in fact, cause weight gain. There can be subjective changes such as bloating, which is not uncommon. And with high dose estrogen, you can also get changes in fat distribution. So for example, breast tenderness, changes in breast size, changes in where fat is deposited. But yeah, generally speaking, there's no evidence of significant weight gain.
All right. Well, the other thing that Dr. PhD was concerned about was, this GF, she's postmenopausal now. Is this going to increase risk of cancers? And, I told him that a combined oral contraceptive pill, the evidence generally shows that it will decrease risk of things like ovarian cancer and endometrial cancer, colorectal cancer, but not cervical cancer, unfortunately.
Well, so I guess the jury, like you point out, there's some evidence that there's a decreased risk of colorectal cancer, ovarian cancer. The jury is still a little bit out on breast cancer. With familial predisposition or obviously history or of